well.
Great. Let me share the screen. So can you see the correct slide share version?
Yep, it's perfect.
Perfect. Okay, great. Well, thank you very much for that kind introduction and the invitation to speak with you all. I usually in this Zoom era sort of start my talk by saying that hopefully one of these days the pandemic will be over and we'll do these things face to face, and that it's not the same thing, but with an introduction that it's whatever minus 20 degrees, maybe it's better to be on Zoom than for me to be in Mississippi, but thank you very much. So I'll talk a little bit about heart failure with preserved ejection fraction. I thought rather than sort of just reiterating data, I'll give a lot of my sort of interpretation of the data and make it a little bit more conversational. But there is a little bit of a slippery slope when you give your interpretation, because it's then just becomes your interpretation, and I could be absolutely wrong. I don't know. Time will prove. But at least it'll give you a little bit of a different flavor of the data than just showing more and more data. Also, my disclosures are at the bottom of the slide. I'll talk a lot about Emperor Preserve trial, but I'm a consultant to BI, and I was on the steering committee for Emperor Preserve trial as well. So please keep that conflict in mind as you hear my comments. Okay. So just a quick word for our friends and colleagues who have interest outside of heart failure and may not necessarily think about heart failure as much. So, growing epidemiology, lots of patients, lots of hospitalizations, lots of mortality. And the prediction is that these numbers will just get worse over time. And in fact, there's some prediction by AHA that over the next decade or so, with the aging of the population, most of the major cardiovascular disease prevalence will increase, but the relative prevalence of heart failure will increase more than any other disease. I don't know in Canada sort of how the reimbursement system works, but at least in the US, the high rates of readmission has a monetary penalty by Medicare, which puts you in a pretty sort of an awkward position that these patients are at a high risk for readmission. But then if your hospital takes care of sicker patients, you also get a monetary penalty. Now, let me take about a 4-minute detour and talk about this whole issue of ejection fraction. And I think we have made life way too complicated as a heart failure academic community. But just to give you a little bit of a background. So remember that in the 1980s, we only had digoxin and diuretics. We really had no therapy for heart failure per se. There was a lot of interest at that time to assess vasodilators in heart failure patients, things like nitroprusside in hospitalized patients or hydralazine nitrates in the outpatient. There was no theory of hydralazine nitrates as targeting oxidative stress and antioxidants and all that kind of stuff. That all came much later. The original idea was balanced vasodilation, preload and afterload. So the question was, how do you do a clinical trial, a multi-center trial where you find people with significant hemodynamic abnormalities and vasoconstriction that vasodilators may work? Purely hemodynamic model, nothing to do with neurohormones. And of course, you cannot do a right heart catheterization on every patient that you want to enroll. And that's where sort of the original trial was said, well, it seems like that there is a correlation that the lower the ejection fraction, the more the vasoconstriction. Again, for the third time, let me highlight, this is not ACE inhibitor, beta blocker era. This is, you're like a no medication. So there was almost a linear relationship, lower the ejection fraction, more the vasoconstriction. So they said, well, why don't we do a trial of these therapies in patients with EF less than 35%? As simple as that, we created a whole disease called heart failure with reduced ejection fraction. The next trial came over and they said, well, we don't have too many patients with EF less than 35. Why don't we make it EF less than 40? So that became the standard. So then came Captopril. Again, nothing to do with angiotensin II, neurohormonal theory, none of that, just simply a vasodilator. And they said, well, is ACE inhibitor a better vasodilator than hydralazine nitrate? So you have to compare. But now the precedence is less than 40%. So the next trial said, we'll also do less than 40%. And then one after another. And then the neurohormonal theory came and ACE inhibitors and beta blocker. But we basically created a disease called heart failure with reduced ejection fraction purely on the basis of logistics and conduct of clinical trial. So then came sort of the late 1990s era, early 2000, and people said, well, you know, but clinically, we're seeing a lot of patients with heart failure whose ejection fraction is greater than 40%, and it could be 70%. So we need to study that. So the first group of investigators who wanted to study this group of patients in a clinical trial was the CHARM investigators. But there was some consideration to study heart failure with normal ejection fraction, except that more than 40% is not normal ejection fraction. Normal is 50 or greater than 50. So in order to not have an evidence gap, you can imagine the CHARM investigator could have done a clinical trial primarily focusing on ejection fraction greater than 50% and call it heart failure with normal ejection fraction, except that we would never have any evidence for EF of 40 to 50%. So therefore, the term was coined heart failure with preserved ejection fraction, not normal ejection fraction. And there we created a new disease called heart failure with preserved ejection fraction, so reduced and preserved. And that set a precedence of all the trials, including EF more than 40%. Well, life keeps moving on. Secondary analyses of the data came in, and it looked like that this 40 to 50%, which is really mildly reduced ejection fraction, acts much more like HFrEF. And like academics do, we all got sort of into an argument, and rather than sort of simplifying things, we chose to do things more complex. And we created these three categories, and sort of, you know, the finger pointing started, oh, you know, the HFpEF trialists are enriching their trials with heart failure with mildly reduced, so that the trial is positive, and all that kind of sort of discussions that go on. But nevertheless, this is where we are today. This is the universal definition by Heart Failure Society of America, Heart Failure Association of the European Society, and the Japanese Society, saying that HFrEF is 40 or less, and HFpEF is 50 or more, and mid-range is 41 to 49. How do I see it? Well, I mean, first of all, I think we should just make it simple and call it HFrEF and HFpEF and just dichotomize it at 50 or 55, whatever you want to choose. To me, it doesn't make a lot of sense to create a third category with an 8 percentage point EF, 41 to 49, 8 percentage point EF, diagnosed by a modality echocardiogram that has a 7% interobservable variability. But nevertheless, that's where we are. So this becomes important that as I go through the evidence on HFpEF, there'll be a lot of sort of subgroup analyses, and I just wanted to give you the idea of how this whole EF discussion has evolved. All studies basically show that HFpEF and HFrEF epidemiology is about the same, 50-50%. So from a prevalence perspective, HFrEF and HFpEF are comparable. But that comparability is evolving. So the recent hospitalization data suggests that there are more patients with HFpEF than HFrEF that are getting hospitalized. Now, that doesn't mean that HFrEF is going down. The overall pool of heart failure is increasing, but the proportion of HFpEF is increasing faster than HFrEF. So the proportional increase is more with HFpEF. Why is that? Well, three reasons. One is there's a lot of age-related changes in cardiac structure and function that puts you at high risk for HFpEF, and the population is aging. Two, comorbidities that put you at risk for HFpEF, like diabetes, obesity, hypertension is increasing. But the third, you know, I mean, I just have an opinion. I really have no data to share for this. Is that maybe part of this is that, you know, in the past we just tended to blame HFpEF on aging and obesity, right? So you get somebody with shortness of breath, you do the whole workup of, you know, pneumonia and COPD and hypothyroidism and asthma and whatnot. And if all of those things are negative, you say, well, you know, this is life, and you're overweight or you're old, not realizing that 6 months ago, you were just 6 months younger and you were equally obese and you did not have the symptoms. But now with natriuretic peptides, more education, more widely available echocardiography, that 15, 20-year-old epidemiology may be changing just because of the issue of recognition. Now, comorbidities are plenty common in heart failure with reduced ejection fraction, but a little bit more common in heart failure with preserved ejection fraction. And we tended to have a pretty linear association in our mind for the correlation between comorbidities and heart failure. So just to give you an example, we said, well, if you have heart failure, you have both forward flow and backward flow problems. So forward flow, kidney doesn't see enough blood. Backward flow is venous congestion and renal congestion, and the two of those things in combination lead to development of renal insufficiency. And on the flip side, you have no heart failure, but you have CKD. So now you have sodium and fluid retention, which leads to LVH, aortic stiffness, and you eventually develop heart failure. So there was this sort of bidirectional association. I think our thought process has now evolved, and that understanding is sort of important because the latest paradigm is that certainly there is this bidirectional relationship, but that's probably the minority of the issue. The bigger issue is that there are these underlying pathophysiologic milieu, obesity, inflammation, oxidative stress, neurohormonal activation, endothelial dysfunction, that is at the core of all of these diseases in combination. And what this paradigm tells you is that of the high-risk patient in their natural history of disease, some people may present with one disease or another first, but you can be pretty certain that other diseases have already started subclinically. So for instance, about 45–50% of the patients with heart failure have diabetes, but what we don't realize that about 35% or so have prediabetes. In other words, insulin resistance in patients with heart failure is seen in about 85% or so of the patients. So this is very common. So multimorbidity is related to some common underlying pathophysiology. And that realization then also makes you realize that if you have therapies that impact this underlying pathophysiology, then the same therapy may have beneficial effects on multiple comorbidities. And again, we're seeing these data with Sclt2 inhibitors, and I'll discuss that. They have beneficial effect on diabetes, on renal insufficiency, on blood pressure, on obesity, on heart failure, just because they tend to impact the baseline pathophysiology. In terms of the outcomes, HFpEF patient mortality rate is a little bit better than HFrEF, but really nothing to write home about. I mean, pretty significantly worse prognosis. So if HFpEF has a 5-year mortality of 45%, HFrEF has a 5-year mortality of 45%, HFpEF may have 40%, but still pretty lethal condition. So equally as prevalent as HFrEF, almost equally as lethal, but the cause of lethality in HFpEF is pretty different as compared to heart failure with reduced ejection fraction. So if you take, say, 100 patients with HFrEF, about 10–15% will die because life happens, cancers and accidents and Alzheimer's or whatever. But 85%–90% will die of cardiovascular causes. And in the cardiovascular cause, predominant reasons are basically two: sudden cardiac death and progressive pump failure. 85–90% of cardiovascular death is sudden cardiac death or progressive pump failure. So the cause of death is so narrow, and the pathophysiology of sudden cardiac death and progressive pump failure is so overlapping that it's easy to come up with therapies that can reduce mortality. When we go into HFpEF, we have not one but two sort of issues. So one is a good third of the mortality is non-cardiovascular, cancers and CKD and whatever else comorbidities that occur. So much bigger proportion of non-cardiovascular mortality. But then the 2/3 or so that is cardiovascular has a much more wider cardiovascular causes. So you have your valvular heart disease and MIs and hemorrhages and strokes and aortic ruptures and stuff like that. So there's such a heterogeneous pattern of mortality that finding a true mortality reducing drug has been a little bit more challenging. And finally, the impact on quality of life and functional capacity is pretty comparable between HFrEF and HFpEF. So to summarize the epidemiology, HFrEF, HFpEF, equally common, equal impact on quality of life and functional capacity, almost equal impact on mortality, and equal impact on hospitalization. So what do our guidelines say to treat this incredibly common and difficult to treat and high mortality condition? Well, basically nothing. So these are the ACCHA guidelines saying that treat comorbidities, cardiac and non-cardiac, things like atrial fibrillation, ischemic heart disease, diabetes, whatever, or treat symptomatically for congestion, so give patients diuretics. American guidelines say the same thing, and the last version of European guidelines said the same thing. And the reason for that is that all the trials done to date, up until Emperor Preserved, were negative. Now, subgroups of some of those trials showed pretty significant benefit, and we'll go over that. But overall, the trials were negative, and none of the trials reached their primary endpoint. Now, the statement that I just made has to be taken with some degree of reservation. So if you look at the TopCat analysis was done with spironolactone and EF greater than 45% patients, and here are the results. So the trial did not achieve its primary endpoint, but there was this sharp distinction in the Americas versus Russia and Georgia. So about 2/3 of the patients were enrolled in Americas, and about 1/3 of the patients were enrolled in Russia and Georgia. So what is not striking is regional variability. We always see regional variability in clinical trials, right? So, the baseline risk factors and treatment standards differ, so there is different. What is striking is that the patients in Russia and Georgia with heart failure are sort of almost like, and I'm being facetious here, are almost immortal. Like the placebo mortality rate in Russia and Georgia is just not compatible with heart failure pathophysiology, which raised a lot of questions whether these patients had heart failure to begin with or not, whether patients were just being enrolled in the trial for the sake of being enrolled, and then these patients were not developing hyperkalemia, so we tested blood test on them, and it looks like that there were no candronone or spironolactone levels found in the blood. So there was a lot of sort of misconduct concerns. But in the Americas, US, Canada, there was significant benefit seen. So I don't know how to interpret these results, but the bottom line is that there are 3 ongoing trials, 2 with spironolactone and 1 with finerenone, and we will get that answer to this question. But as of right now, the trial overall did not achieve its primary endpoint.
Can I just ask Javed, like, just for spironolactone, like, how would that improve outcomes in this population? Is it through electrolytes? Is it modulation of like hormones? Or like, what do you think?
So all of the above, right? So there are 3 things that one can postulate. So one is natriuresis and decongestion, except that the doses that we use in these patients are just not natriuretic doses, 25 to 50 milligram. We're not using 100 milligram or high doses. So the second thing is that avoiding hypokalemia and actually pushing the potassium a little bit even on the higher side can mitigate the risk of sudden cardiac death. So that has been proposed. But obviously, the biggest proposal is the issue of aldosterone and fibrosis. So long-term aldosterone is associated with fibrosis, both of the heart and the kidneys. And we saw this signal, but also remember that finerenone in diabetic kidney disease also improves kidney function as well. And there the theory is mostly about the effect of aldosterone on fibrosis. So then we move on to ARNI, valsartan sacubitril. So again, overall trial was sort of negative, but when they looked at the subgroup analysis, so maybe I should have clarified this in the beginning of the talk. So my biggest conflict of interest here is that I'm a Bayesian and I'm not a frequentist, so I don't sort of live and die by p-values. But the clinical trial world is all frequentists and they live and die by p-values. To me, p-value of 0.059 and 0.049 is just not any different. And as far as I'm concerned, Paragon trial was a positive trial. The issue is not 0.059 versus 0.049. The problem is whether the clinical benefit is worth it or not. And here, what we are finding in the overall trial, that the primary endpoint benefit was sort of really modest, and then also the mortality was sort of not seen. But they had a pre-specified analysis on the basis of median EF. So this funny number of EF of 57% is because that's where the data sort of fell, with 57% being the median ejection fraction. But less than median ejection fraction, they were pretty impressive benefits. So what do we discern from that? Well, so one thing is that it looks like there's heart failure with mildly reduced ejection fraction patient. They tended to work with Spironolactone, they tended to work with charm with candesartan, and now they tended to work with ARNI as well. And on the basis of that, in the US, the FDA did give it an indication. So the original post-paradigm indication was heart failure with reduced ejection fraction, and they just basically said heart failure with chronic heart failure. But then they added this line: benefits are most clearly evident in patients with left ventricular ejection fraction below normal, and left it to the clinicians to decide what is sort of below normal. But I think it's pretty reasonable to say that heart failure with reduced and mid-range ejection fraction or mildly reduced ejection fraction should be treated with that. The question is that for the true HFpEF, what is the therapy? Now, we all get pretty excited about clinical trials and sort of the high-tech statistics, but at the end of the day, remember that congestion is a problem in these patients, and congestion occurs much before hospitalization. And we at least have proof of concept that by effectively managing pulmonary pressures, both by diuretics and by using effective medical therapies, not only have HFrEF, but there is substantial improvement in HFpEF. And now there's another paper, which hopefully will be coming out soon, the secondary analysis of the GUIDE-HF trial, again showing the same result. So that brings me to the issue of pathophysiology. So we discussed the epidemiology, we discussed some of the clinical trials, some of the trends in benefit, but really not a positive trial. So that begs this issue of what is the pathophysiology. So if you sort of talk to the real HFpEF gurus out there, the most favored theory right now is that it's an issue of nitric oxide pathobiology, which has gone sort of haywire. So let's sort of think about it. So one way to conceptualize this, or at least that's the way I'm thinking about it, is that HFpEF is a disease that it starts in the heart and goes to the body. So whatever it is, myocardial infarction, adriamycin toxicity, myocarditis, whatever it is, your heart function goes down, neurohormonal activation occurs, and that then leads to hemodynamic abnormalities and cellular abnormalities and CKD and skeletal muscle changes and mitochondrial changes and ATP and all those things. So starts in the heart, goes into the body. Here the theory is opposite, that the disease starts in the body that eventually affects the heart. So the most favored theory is this, and I'm not sure that human biology is this precise. So the theory is that you have this metabolic sort of milieu with obesity, adiposity, that leads to oxidative stress. Nitric oxide signaling pathway is abnormal. Nitric oxide is obviously in endothelium all across the body. Nitric oxide signaling leads to soluble guanylate cyclase, CGMP, PKG signaling, which is prevalent all across the body, kidneys, heart, vasculature, and that eventually leads to sort of LVH and stiffness of the heart, atrial dysfunction, and you develop HFpEF. I think this theory, in my opinion, and again, I sort of highlighted at the beginning, I'm going to be giving a lot of my opinions, but time will tell. I think that this has been made too precise. And the reason I said that is that not one, not two, not three, we now have 4 trials in HFpEF that have targeted the abnormal nitric oxide pathobiology, and all 4 trials have been negative. We used nitrates, we used inhaled nitrites, we use PDE5 inhibitors, and we use soluble guanylate cyclase stimulators. And all 4 attempts to normalize the nitric oxide signaling pathway in HFpEF have not shown improvement in outcomes. So I think this is a problem for sure. I struggle with two things. One, how much of this is precedent versus antecedent? And two, how much of this is a part of the overall problem rather than the overall problem? I'll make some more comments about that in a minute. The other theory which is out there, to which intellectually I'm really attracted to, is heart failure a disease of the heart or the kidney, or HFpEF is a disease of the heart or the kidney. So here's what I mean by it. In patients with heart failure and reduced ejection fraction, you have neurohormonal activation, and angiotensin II and aldosterone leads to sodium and fluid retention. I sort of understand that. Now, when you come to HFpEF, I'm not talking about your patients with eGFR of 25 or 30. Remember that the median eGFR in HFpEF patients is 60. So half the patients have eGFR even more than 60. I realize that eGFR of 60 is not normal, but it's pretty darn good. And in patients with HFpEF, you actually don't have much neurohormonal activation. So if your renal function is relatively preserved, or your GFR is relatively preserved, and you don't have much neurohormonal activation, why do you have fluid retention? If you take an extra slice of pizza or have an extra beer, you should just pee it out. So that leads to the theory that the primary problem is actually sodium avidity. This also can understand some of the differences with African American patients developing HFpEF earlier and to much worse extent, and the propensity to hypertension. So the theory here is that you have either a proximal or distal tubular propensity for sodium retention, or a decreased propensity for sodium excretion at the glomerular level, whatever the molecular mechanism might be. But it is chronically over decades, sodium and fluid retention subclinically, no symptoms, which leads to the subclinical, some degree of congestion, stiffness, and that then leads to endothelial dysfunction and all of those things that subsequently happen. And then on top of that, you add some hypertension, some LDH, some diastolic dysfunction. A person may be living perfectly fine with that hypertension, age-related, and die of some other reason, except that their reserve has just gone down. And then you have any degree of fluid overload with a decreased reserve, you go into the syndrome of HFpEF. So what are some of the data that suggest that there may be something in this theory? Well, the lower the eGFR, the higher the risk of heart failure. We do know that drugs that have some impact on natriuresis, granted that that's not the major impact, and these drugs do a lot of things, actually have substantial improvement in HFpEF outcomes. So chlorthalidone reduces the risk of incident HFpEF pretty significantly compared to, say, lisinopril in hypertensive patients. Spironolactone, again, we just discussed, we don't give natriuretic doses, but nevertheless, sodium avidity may be affected with the anti-aldosterone effect and have heart failure, HFpEF potential benefit. And then empagliflozin or Sclt2 inhibitors have substantial preservation of renal function, and in diabetes patients really prevent the development of HFpEF as well. So lots of theories that it may be actually a kidney disease. So how do at least I summarize all of these data together? So this is sort of the story that I would like to believe in, and that is that human biology is complex. We like to make it simple and have sort of unidirectional, that A led to B, B led to C, and the drug C affected D outcomes. But in reality, things are sort of really complex. So if you have overt adiposity and obesity, or covert adiposity, so there's a lot of data that in Asian populations, the BMI may not be very high, but the relative proportion of lean mass is lower. So visceral adiposity and subcutaneous adiposity nevertheless is a problem, even if you don't have substantially high obesity by the traditional metrics of BMI. So this adiposity and the inflammatory milieu and oxidative stress is clearly part of it. Some degree of neurohormonal activation in the long run is associated with cardiac structure and functional changes, vascular structure and functional changes, renal structure and functional changes, and systemic changes like mitochondrial inefficiency. And it's the combination of all of these things that leads to development of all of these diseases: hypertension, heart failure, HFrEF, HFpEF, chronic CKD, diabetes, etc. And the reason I like this paradigm, because this also makes you understand why therapies that can impact this paradigm can have beneficial effect across the spectrum. So if you look at Sclt2 inhibitors, we now have data, either in humans or in animals, that they are associated with improvement in cardiac structure and function. So LVH reversal, reverse remodeling, diastolic dysfunction, fibrosis, atrial function. They improve vascular structure and function, so decrease vascular stiffness, endothelial function. They have systemic effects, so whether it is beta hydrobutyrate levels, whether it is fatty acid oxidation, but nevertheless they improve mitochondrial efficiency and improve the energetics. There are data with improved autophagy, sodium hydrogen exchange blockade, and reduce risk of sudden cardiac death because of calcium homeostasis on the heart. And of course, all the impact on osmotic diuresis, natriuresis, and decrease intraglomerular pressures and preservation of renal function. Now, if you believe in all this pathophysiology, pharmacodynamic, and mechanism of action data in humans or animals that we have now with SGLT2 inhibitors, several things become pretty easy to comprehend. First, that SGLT2 inhibitors are good anti-diabetic agents and they should be used for diabetes. But if a drug can do all of these things, we truly have cardiovascular risk-modifying agents that go way beyond the treatment of diabetes. It has nothing to do with diabetes alone. And if you were to do cardiovascular trials, that those trials should include all patients with or without diabetes. And then the second thing is it also puts into that framework of comorbidity that I mentioned earlier, that the same drug impacting multiple different diseases state, it sort of makes sense. So that brings me to the Emperor Preserved trial. When these data came out, I sort of remember having endless discussions with our sponsor colleagues in pharma. Multiple people were going to multiple different pharmaceutical companies, Boehringer Ingelheim, AstraZeneca, Janssen, pleading that not only should we be doing heart failure trials, these trials should be completely agnostic of presence or absence of diabetes. Just doesn't matter. Don't even stratify. Just enroll patients. Forget about diabetes. And you might imagine that these assets in pharma were in their endocrine section run by endocrinologists, and there was a little bit of concern about using these drugs that have never been tested in non-diabetic and just do it in non-diabetic. And I'm so glad that we ended up doing these trials. So 2 large heart failure trials with preserved ejection fraction were started. As you know, there were 2 large HFrEF trials that were also started. They have been published, presented, part of the guidelines. That's not what I will focus on, but happy to answer questions. But Emperor Preserved, about 6,000 patients with EF greater than 40%, randomized to empagliflozin and placebo, looking for 3 outcomes. So the first outcome was cardiovascular death, heart failure, hospitalization. So here are the results. There is a saying in clinical trials that if you need a p-value to prove your point, your data are not too strong. So here the data speaks for themselves. The curves have started separating early, continued to separate, a highly statistically significant result, and a relative risk reduction, which is very clinically meaningful, a 21% relative risk reduction in the primary endpoint. Now, when we look at the subgroups in heart failure with reduced ejection fraction, they are usually very boring because if a drug or device works, it tends to work in any situation. But because up until now, we have never had a positive trial in HFpEF, there's a lot of interest in subgroups in HFpEF, and people think that, oh, diabetes is a different disease. Paragon had a sex interaction, that male and females work differently. So we looked at a bunch of different subgroups and basically found really nothing. So if you look at the top box, diabetes, I mean, there is just no difference in patients with or without diabetes. Then really no interaction with sex in men and women, body mass index, CKD, atrial fibrillation, baseline ischemic heart disease, medications, etc., which then leads us to this whole issue of ejection fraction. Now, if you were a true frequentist clinical trialist, and that's what sort of the New England Journal editors' interpretation was as well, is that, if this was not ejection fraction with all the history that I gave you, and if this was, say, some entirely irrelevant continuous measure, say, I don't know, serum chloride level, the interpretation was that there is just nothing there. All three groups benefited across the spectrum of serum chloride levels. Your point estimate hazard ratio is not only to the left of the unity, is significantly to the left of the unity. And the P trend is not only negative, is highly negative, it's greater than 0.2. However, this is not serum chloride, this is ejection fraction. There's a lot of emotions attached to it. And if you look at the pre-specified three groups, 40 to 50, 50 to 60, and greater than 60, one good thing is that we had a third, and a third of the patients. So there's pretty fair representation in the three groups. There is this visual reflex to see that the point estimate goes down as you go from EF less than 50 to greater than 60. And this sort of evokes all of those same emotions that we had with Paragon, that these are all drugs that only work in heart failure with mildly reduced ejection fraction, and that we truly don't have any therapy for the so-called true HFpEF, which is greater than 50% ejection fraction. So we did all of those analyses. This data is being peer-reviewed right now, but were presented at AHA. So if we exclude all patients with EF less than 50% and only focus on 50 and greater, the primary endpoint still reaches the nominal p-value. There was a 17% relative risk reduction, the same risk reduction for total heart failure hospitalization. If you just look at it linearly, so what we ended up doing is that because we had data on 10,000 patients, you can just combine HFrEF and HFpEF all together and just look at it across the spectrum. Now, remember, at the two ends of the spectrum, the confidence intervals are really wide because the number of patients are fewer, right? You have many more patients with EF of 40% than EF of 15% or 75%. But nevertheless, the linear p-value trend was completely negative. Benefit was seen across the spectrum. And then these are the spline analysis. So in my opinion, there is a little bit too much made out of that. I can give you again my interpretation, but time will tell. So people are saying that, well, it doesn't really work over the ejection fraction of 65% and that there is attenuation. First of all, the hazard ratio is below 1 across the spectrum of EF, and then 65 to 70%, it works less, but then all of a sudden, 70 to 75%, it works even more. And that is a little bit more visually easy to see when we divide the EF by 5%. So, all of you may have a visceral reaction saying, why would you even do this analysis? I mean, it's ridiculous that you have an echocardiogram with a 7% EF variability, and now you're doing 5% EF cuts. Well, the reason we did this analysis is that the peer reviewers wanted it for the paper. This paper has been published now in European Heart Journal. So again, one can see. So how do I interpret these data? My interpretation is that this is complete noise today. First, when a person comes into the clinic to see you, that you have one ejection fraction. Remember, these data are averages of hundreds of patients, but when you see a patient with EF of 65%, that patient may have an EF of 58% or 72%. Second, this to me today is noise, and what I don't know is how to explain the noise. For instance, I don't know whether there were patients that were sneaking in with atrial fibrillation without the syndrome of heart failure. I don't know whether amyloidosis and SGLT2 inhibitors work or not. To me, the clinical interpretation is that today, all patients with heart failure and preserved ejection fraction should be treated with empagliflozin. And in about 3 months or so, when we have the DELIVER trial with dapagliflozin and HFpEF come out, we will change our mind when more evidence comes out. If again we see a trend that there is attenuation over 65%, then we need to go back and look at and understand what is this EF with supranormal EF. And if dapagliflozin does not show this signal and we see benefit across EF, then basically we should accept that SGLT2 inhibitors improve outcome across the spectrum of EF. So that's at least the way I am interpreting this EF data. And now what we ended up doing was really sort of dig through all the supplements of all the previous trials and whatnot. And all of these trials had different ejection fraction enrollment criteria, some greater than 40, some greater than 45. And we excluded all the people with EF less than 50% so that we can have a sort of a quasi comparison of only those patients with candesartan, with digoxin, with irbesartan, with spironolactone, with valsartan, sacubitril, and with empagliflozin, only on those with EF greater than 50%. And sort of a picture is worth 1,000 words. One can see that none of the previous trials were statistically significant, and both the magnitude of benefit in HFpEF and the statistical significance, at least to me, is convincing. So then we go from the first primary endpoint of cardiovascular death, heart failure hospitalization, to total heart failure hospitalization. Again, a pretty substantial 27% relative risk reduction, which then leads us to the renal benefit. So remember that ACE inhibitors cause a renal bump, creatinine bump, or a lower in GFR, which we know is not adverse renal function. It's actually, we know that ACE inhibitors are good for renal function in the long run, but that is due to intraglomerular hemodynamic changes. You stop ACE inhibitor and that initial drop reverses. SGLT2 inhibitors are exactly the same. There is an initial drop in eGFR followed by renal function preservation. So the third endpoint of eGFR, there was a preservation of 1.36 ml per minute per year, which was highly statistically significant. What does that mean? That means is that aging, comorbidities, and heart failure related decline in the placebo, despite 80+% RAS inhibitor use at baseline, was almost linear, and that was slowed down by 1.36 ml per minute per year. Now, if you look at the right side of the slide and actually look at the clinical renal event, things like dialysis, transplantation, whatnot, we are seeing absolutely no difference. So there is a discrepancy on the left side of the slide and the right side of the slide. The left side of the slide shows a substantial preservation of renal function, and on the right side of the slide, you don't see any renal benefit. So how do you reconcile the two? Well, there are 3 ways to answer this. So the simplest answer is empagliflozin does not improve renal function in HFpEF. That's what we are seeing. Except that that makes no sense. First of all, we have 4 trials in diabetes, 2 in CKD, and 2 in HFrEF that show significant renal benefit with these drugs. And what we will be basically saying is that there is some sort of a magic that happens at EF of 40%, and that at 39% there is renal benefit, and that at 41% there is no benefit. So that obviously is not a good explanation. So the second explanation is that eGFR benefit of 1.36 ml is just not good enough. We really need to have more renal function preservation. 1.36 is kind of puny. Well, that doesn't hold out to be true either. On the left of this slide is a meta-analysis of 47 randomized controlled trials over 60,000 patients, showing that if you have a renal function preservation of about 0.75 ml per minute per year, you almost have a guarantee of slowing the progression of CKD. And here we have 1.36, almost twice as more as 0.75. So that explanation doesn't make sense. So what is the explanation? In my opinion, this is entirely an issue of definition and not an issue of biology. What I mean by that, What I mean by that is that, remember, these are heart failure trials, not CKD trials. So we don't enrich patients for CKD events. We have no albuminuria criteria. We have no GFR cutoff that only less than 60 or less than 45. In fact, the median eGFR in this trial was 60, and half the patients were more than 60 eGFR. Not only do we not enrich for renal events, we enrich for heart failure events. So these patients have a lot of heart failure hospitalizations. So the average follow-up is pretty small, and this trial is only 2 years. So how do you take a group of patients with eGFR of 60 and have them become dialysis dependent and transplant dependent in 2 years? Well, that's just not going to happen. So how do you assess renal outcomes? So in the renal world, there is a consensus that some threshold of reduction in eGFR is so big that it is considered to be as bad as having a renal event. So people who study rare renal diseases like Alport syndrome would say a 30% reduction in eGFR is equivalent to having a renal event. So that would make sense, right? So if in Emperor Preserved, we started in 6,000 patients with an eGFR on average of 60, and if in 2 years it went down to 40, which is a 30% reduction, all of us will agree, man, this is really a big drop in eGFR. That is a good idea, but not for SGLT2 inhibitor or ACE inhibitor. That threshold works for drugs that are intraglomerularly neutral. They don't have intraglomerular hemodynamic effect. But with SGLT2 inhibitor, because of a drop in eGFR, you cause a lot of noise despite of renal function preservation. So some people say, well, why don't you use a very strict definition of 57% drop in eGFR, which is equal to doubling of serum creatinine? Well, that makes sense, except if you use that threshold, then it's the same thing as dialysis or transplant. In 2 years, we're just not going to have an event. So what we ended up doing in this trial is that we used a 40% threshold, neither 30 nor 57. And the bottom line is that it worked in HFrEF and it did work in HFpEF. That's as simple as that. We did a secondary analysis looking at a 50% threshold. Now, granted, this is all secondary analysis, and all of a sudden the world makes sense. First, when we move from 40% to 50% threshold, we decrease the number of events into half, so the confidence interval is wider, but all of a sudden, the point estimate is 22% relative risk reduction in the renal event rate, which is very consistent with previous data. So in my opinion, this is all an issue of definition and not biology. So we're running out of time, so I'm just going to cover one more topic and then I'll just stop and might as well have some discussion rather than going through all the slides. So, our patients obviously want not only clinical outcome, but quality of life to improve. So that was tested with Kansas City Cardiomyopathy Questionnaire. We saw a significant benefit first time when we measured at 12 weeks and was sustained when we measured it last time at 52 weeks. Well, what does a 1.5 point difference mean to a patient on an average? Well, not much. So we did some responder analysis. Again, same benefit in NYHA class. We did mention and measure NYHA class as early as 4 weeks and as late as 3 years. And the benefit was seen consistently early and late. Whether it's a heart failure benefit with sick heart failure admissions, CCU, inotropes, a benefit was seen, or less sick heart failure admissions like just outpatient IV diuretic intensification. The benefit was seen as early as 18 days. So the Kaplan-Meier curve first achieved statistical significance at 18 days. Really not much effect on blood pressure, 1.2 mmHg. We did not have to change any of the other medication. So I missed the responder analysis slide. Sorry about that. So the bottom line is that if you look at KCCQ improvement are 5 point, 10 point, or 15 point at 3 months, 8 months, or 12 months, or symptoms, overall summary score, including quality of life, or CSS, including physical limitation, all 3 scores at all 3 thresholds at all 3 time points were improved. And that data just came out in circulation about 2 weeks ago. Very safe, very well tolerated, really low risk profile, and actually no significant difference in ketoacidosis and hypoglycemia in the 2 groups. So the trial was set out to answer these 3 questions. All 3 were statistically significant and clinically relevant positive. This is just a comparison, which I already show you graphically. And if you look at Emperor Reduced and Emperor Preserved trials side by side, I mean, these results are identical, again, highlighting that we may have a therapy across the spectrum of EF patients and that we will learn a ton with the liver trial. So let me just stop here and not go through the rest of the trials and maybe answer some questions. But thank you so much for the invitation.
That's great. That was fantastic. Obviously, just really incredible kind of amount of data. So I'm going to just take some questions from the chat room. There's one question from Brad about, can you use empagliflozin in people with like really poor renal function, like low GFR, less than 30 type? Like, what do you think about those population?
Yeah, certainly. So DAPA-HF used a GFR of 30, like all of the trials, but DAPA-CKD, which was a CKD trial, used a GFR of 20, and both Emperor trials, Emperor Reduced and Emperor Preserved, use a GFR of 20. So we can use all the way down to eGFR of 20. Also, all of these trials that I mentioned, during the trial, when the GFR fell to less than 20, the drug was not discontinued and was just basically continued all the way to end-stage kidney disease. There is a good case to be made that in end-stage kidney disease, these patients will benefit also, but those trials have not been done just yet. So today, you can initiate all the way to GFR of 20, continue to end-stage kidney disease, but it's contraindicated in end-stage kidney disease and dialysis.
That's great. Gord, welcome to our rounds. Do you want to ask your question, Gord, or are you still there?
Yes, my question to Javed is what do you speculate the effect of dapagliflozin will have on renal outcome in the patient with preserved heart failure with preserved ejection fraction? Data will be available, I guess, in 3 months.
Yeah, I mean, I would bet that the data will be positive. They have more patients, slightly more, but they have longer follow-up, and they have a little bit sicker population than Emperor Preserved. And all of these 3 things put together bode well that not only the cardiovascular, but the renal benefits will be statistically and clinically positive. Is my
Thank you. Thank you.
Kareem, thanks for coming as well. Go ahead.
Thanks for a very fantastic presentation. I'm a cardiologist at North York, which is affiliated with Sunnybrook, and I run the heart failure clinic there. I think I have 2 questions. The first question is, I really was interested with the history behind the EF. And, should we be changing our approach to our heart failure patients in which we're thinking whether neurohormonally, if the angiotensin receptor or the angiotensin neurohormonal system is on or off? And maybe that will help us treat patients more effectively. That's the first question. And the second question is, you outlined, the theory of HFpEF in terms of pathophysiology, and it's obviously looking like it's going to be a systemic disease. And should we be moving more to prevention as opposed to treating all these factors, which is going to be challenging over the next many years?
So Kareem, simply brilliant, and cannot agree with you more on both points. Let me tackle the second one first, and that is that we have so many effective ways of prevention of heart failure, but we just don't focus on it. I mean, Greg Fonero and I wrote a viewpoint that came out in JAMA about 2 weeks ago, that if you look at the lipid guidelines, they call high-risk patients like, 3% over the next 5 years or whatever. And you look at heart failure, there's like 15% risk, and we just kind of just ignore it. It's a mindset issue. Hypertension, 50% reduction in new onset heart failure. SGLT2 and type 2 diabetes, 30% reduction. Bariatric surgery in people who are indicated, 60, 70% reduction. I mean, there are powerful tools to prevent heart failure. Of course, lifestyle and low sodium diet and exercise and alcohol and all that kind of stuff also matter. So cannot agree with you more that in the primary care and general cardiology setting, a lot of the heart failure can be prevented. Now, the first question is actually really, really, really insightful. So at least the way sort of I see the world, so I'm sort of a little bit of a simplifier in my mind. So right now our colleagues are saying, well, HFpEF should be defined differently in men and women with a different threshold, and we should do this and we should do that. At least the way I see it is that HFpEF, heart failure overall has multiple pathways through which it develops and progresses. Neurohormones are part of that, and then there are non-neurohormonal mechanisms. So the neurohormonal mechanism has a linear relationship. The lower the EF, higher the neurohormonal, more the benefits with neurohormonal blockers. So if you use ACE inhibitor or beta blocker or valsartan sacubitril, if your EF is 25, you benefit much more. If your EF is 45, you still benefit, but not enough. When your EF is 55, there's not much hormonal benefit and you don't benefit as much. I mean, this to me just makes sort of simple sense. And SGLT2 inhibitors that impact non-neurohormonal pathways of progression of the disease are not dependent on that, and you have benefit across the ejection fraction criteria. So if I were the king of the world and the sole guideline writer, I would prefer imprecision. I would prefer imprecision for applicability, generalizability. I would just say if your EF is 55 or less, give quadruple therapy. More than 55, give SGLT2 inhibitor, and it is as simple as that in my mind.
Fantastic, thank you.
Stephanie, do you want to say your last word, or do you have any comments?
Actually, that was exactly what I was going to ask about, whether you would do away entirely with the heart failure with mid-range or mildly reduced ejection fraction, because as you may already know, the ESC just came out and kind of redefined their guidelines with respect to HFpEF mildly reduced ejection fraction. And it makes sense that, it would be 55% or 57%, whatever new cutoff. And it sounds like in your mind, that category would be mixed in with the HFrEF folks. My question actually is regarding the safety of SGLT2 inhibitors. At Sunnybrook, we have this institutional policy that was made a very long time ago when SGLT2 inhibitors, I think, first came out for the treatment of diabetes. And there was a huge concern over diabetic ketoacidosis. And as it stands, we still cannot prescribe SGLT2 inhibitors for our inpatients here at Sunnybrook. I was just wondering what your thoughts were regarding that, given the light of the results from the MPulse trial that came through, and whether you had any comments for people listening here, because we are trying to change the policy.
Yeah, so many comments. So first of all, sort of safety first, and you have one bad outcome, and then people will not give the drug to the next 100 people without the risk factor. So safety first for sure. And again, I don't want to make the light of it. The fact that we saw no imbalance in ketoacidosis. John McMurray had a great slide. I need to borrow it from him. That the number of people in heart failure trials with SGLT2 inhibitors that have developed ketoacidosis is less than the number of people who have developed angioedema on ACE inhibitor trials. So the risk is there, but it's a really small risk. But that risk can be mitigated. And the reason why Emperor preserved there was no imbalance is not because these drugs don't put you at a high risk of ketoacidosis, but because you can take measures to mitigate that risk. So first of all, just make sure that you don't use it in type 1 diabetics, right? So type 1 diabetics are out, it's contraindicated. Second, in patients with type 2 diabetes, if somebody's hemoglobin A1C is 12.5, the question is this a burned out type 2 diabetic, which is really have type 1 diabetic pathophysiology? So just measure a C-peptide level. Just sort of get a sense that is this just a non-compliant patient, or is this an insulin deficient patient, right? So you can get sort of some sense. That is going to be the case. I can bet you 2 in a year. Vast majority of the patients are just non-compliant and there. In that group of patients, starting SGLT2 inhibitor is sort of not an issue. The problem with ketoacidosis is not as much as development of ketoacidosis versus delayed diagnosis. So what ends up happening is that if your type 2 diabetic patient calls in with nausea, vomiting, I'm sort of really feeling bad, you say, well, why didn't you, check your glucose? Oh, your glucose is 700, go to the emergency room, you have DKA. because of the mechanism of action of this drug and osmotic diuresis, you ask the same patient to check your glucose, and your glucose is 220. You know, it's not normal, but it's not 600, and we don't mentally connect that despite of not very high glucose, you still could be ketoacidosis. So you just say, you know, it's a viral gastroenteritis, sit home, and like 12 hours later, the person's like really sick and they show up into the emergency room. So again, having a little bit of a low threshold, having the idea who are the patients, you can mitigate the risk. Remember the DARE-19 trial that Mikhail Kosybro did with dapagliflozin in COVID-19 patients. These are the patients that are enriched for renal failure, and you saw no renal signal. In fact, there was renal preservation. And in a PULSE trial, the average day of hospitalization, the average day of starting the therapy was day 3 on IV diuretics, and there was no renal worsening signal at all. So I think the issue is not inpatient initiation. The issue is just some simple techniques to mitigate the risk.
Thank you
Sorry
so
for the
much.
long answer.
Thanks a
That was
lot.
an
So we
excellent-
definitely should change our policy. Maybe we'll get you to come and write to our ICU guys. That's pretty concerned. But I would like to thank everybody for coming. Thanks, Javed, for giving us this incredible talk about heart failure. And I hope that, you know, we kind of take something out of it and just, you know, I think heart failure is such a big topic that we all want to kind of get better in managing these patients. So thanks a lot. Hope
Thank
to
you.
see everybody soon.
Bye-bye.
Bye.